Gender equity is a human right, and it is central to excellence in patient care. It lifts the economy and it makes our communities healthier and safer. This devastating pandemic has shone a spotlight on inequity, but has also given us a unique opportunity to put things right.
In this episode of Coda Zero, we discuss the issues of gendered inequity, how it impacts on healthcare providers and healthcare consumers, how it is compounded by racism, violence, and the pandemic. And we ask what each and every one of us can do, because each and every one of us has a role.
We're proud to collaborate with CommBank on this educational project about gender equity within medicine. We're excited to see the launch of CBA's The Next Chapter programme, addressing domestic and financial abuse.
I stand on Bunurong country. Chris is on Gadigal country, and our guests come from as far away as Powhatan country. We acknowledge the traditional owners of the land upon which we stand, and we pay our respects to the elders, past, present, and emerging. Wherever you are in the world, we ask that you take a moment to acknowledge the traditional custodians of the land upon which you stand.
Welcome to Coda Zero.
Welcome to Coda Zero.
So speaking of the power of stories, we now move on to Amy Tunick. Your TED Talk, Amy, highlighted the foundational inequality within Australian systems and societal structures. How does a legacy of white supremacy impact healthcare in 2020?
Yeah, so just want to say amazing panel from Kate and Elizabeth so far. I'm really enjoying hearing what everyone has to say. And it's so troubling, you know, as Elizabeth's saying and Lauren has mentioned, the way we see the same power imbalances repeated again and again and again, whether it's education or healthcare or politics or even just discussions around what should a home and a family look like. And I was thinking about, you know, there's often controversy around things like singing the Australian anthem, right? And something that people are taught about Australia is that we are young and we are free. I disagree with both of those things. This continent is home to the oldest continuous cultures in the world. Over 100,000 years of amazing community has taken place and is taking place on these lands. But what is young are our systems that we're currently experiencing this inequality and oppression within. And that has there's two sides to that. Firstly, it's terrible what's happening, but on the other hand, it's a young system. So being disruptive and pushing back shouldn't be seen as threatening as it is. If people genuinely are on board in terms of wanting to work together for us to have that even playing field. However, if it feels threatening for us to talk about pushing for equality, then perhaps people feeling threatened aren't that on board with us actually being treated equally. So within the healthcare system, when I think about the legacy and the ongoing racism, I think about people like Naomi Williams, a Wiradjuri woman who in New South Wales died because she was repeatedly refused treatment in hospital. Her and her unborn son died of septicemia. I think about my own mother who attended at least 8 different emergency departments over 2 years and was constantly sent away with Panadol. I think about women and Black women whose pain is ignored. And when you sit in that intersection of Indigenous or Black and being a woman, how often you're seen as just there for pain relief. It turned out my mum had, they don't stage lymphoma, but the equivalent of stage 4 lymphoma. She was given 3 months to live. But it took years and she was in so much pain and she was constantly dismissed. And so I think about how we live today in systems that are led by often white men, and they're populated with research that has involved primarily studies, Lauren and I were talking about this earlier, that are populated primarily with white men, and data and teaching, you know, from the training level, whether it's a tertiary hospital or we're going back to an undergraduate perspective where you can go through your whole degree without ever having a woman professor, let alone an Indigenous woman professor, lead and teach you elements of what you're there to learn in the health faculty and field. And the way that that comes together so that Indigenous peoples, Indigenous women and women in general will experience being dismissed, being disregarded, and often having really basic boundaries crossed. I live in a semi-regional area, so we only have one major hospital here. I'm well qualified in terms of the Western system. I've got a couple of degrees, but that doesn't stop specialists when I go to see them from putting aside my humanity, because they see the word Aboriginal on my documentation and they think, well, this is a good time. Like, you've waited 6 months for this appointment, you're in a lot of pain, but I think this is a good time for me to ask you if you'll come in and do cultural training for my staff. This crossing of boundaries is something that we experience a lot, and it's quite literally killing us. And it is reflective of the systems being built in a time where Indigenous people weren't counted as people. My grandfather, when he was born, we still weren't counted as people here. And that legacy lives on, because at no point have we kind of stopped the system, rebooted it, booted out the people who were writing the papers dehumanizing us. Like, that's never happened. And so you have the same teachings that are really deeply embedded within these systems now, perpetuating the harm.
Amy, you touch on this almost double whammy of being both female and Indigenous. Can you tell us more about how your experiences are different to those of a non-Indigenous woman like myself?
Yeah, sure. So, I mean, a saying that I think would hit home for a lot of Black women and Indigenous women is, what police are to Black men, doctors are to Black women. So the violence that we experience in the system is, women in general do experience a lot of violence within the medical system. You take something like endometriosis, which is debilitating. We've known about it for so long, and yet the research and the awareness of it generally is just not there, right? So women in general have a really hard time within medical fields trying to get help. But for Indigenous women, we also experience the fear of navigating systems that actively do harm to us. So, within Australia, we have the era known formally as the stolen generations. But what a lot of people don't realise is the stolen generations didn't stop. More Aboriginal children are removed today than during that era. And so as an Aboriginal mother, I know that when I enter any system run by the state, so the public health system, I'm at risk, because I'm white passing, so I'm not likely to be stopped on the street by a police officer, but I'm very much seen as Aboriginal in the health system. It's there in my medical records. If you ask me my medical history, I am stereotypically Aboriginal. My grandfather has diabetes, you name it. But I'm also at risk from the harm that we know is perpetuated against Aboriginal women and mothers. So it inhibits your ability to be open with your doctors. Because if I let on that I'm really stressed and overwhelmed, is that going to result in a report to community services because I'm also a mother? If I don't agree with your diagnosis about my child or what you're recommending, I'm more likely to experience the threat of, well, we're going to contact community services. You're going to do it my way. I know, because I'm friends with lots of white women who are also parents, that the way I experience the health system as a mother is different. I know it's different for myself. I was thinking about, so during my pregnancies, I experienced hyperemesis gravidium, how you say it, HG. So I was a regular in my ED getting drips, couldn't keep anything down the whole time. And a doctor who saw me once during that time called me up a few months later to ask to store their furniture in my garage while they went on holiday. Like, my boundaries are so regularly crossed. I was getting a test last year, and the nurse who was putting the radioactive stuff into my body was looking at my chart while they were putting the needle in, said, "Oh, you're Aboriginal." My daughter is very interested in Aboriginals. Can I give them your number? And when you're in these positions, the power imbalance is unavoidable. If I say no, well, I've got to lay on this slab thing under this machine for, hours. This person has a needle they can poke me with. Will I be dismissed? Will my report not be done properly if I piss you off? And so you're forced to then be that person who says, oh yeah, sure, no, you can totally breach my confidentiality and my ability to access healthcare safely because your offspring thinks my culture is interesting. And so I think it's that extra layer of systemic harm, constant fear of threat and of state intervention, and the need to just get help because there's something wrong with your body, and like health isn't my thing. I can't diagnose myself. And I do think that intersectionality is where the violence and the risk and the trauma is increased.
Amy, thank you for sharing those stories. That is just utterly shocking and unacceptable. I guess from your perspective as an academic working in educational systems, what is the role of academia and higher education in disrupting those systems, or, you know, to achieve equality in health?
Yeah, so I mean, for health professionals, whether you're in research or you're in that public interface as a healthcare provider, I think education is really important. So starting at that foundational level of how we train up health professionals, we need more Indigenous healthcare professionals in academia, where 0.3% of the higher education workforce, Indigenous academics. We have quite a few Indigenous people in health, particularly in nursing and in medicine in general. We need to see more people trained up and supported to last in academia. Academia is, we have high attrition rates because it's quite a violent space for Indigenous people. We then also need the non-Indigenous people teaching and working in health to unpack some of their own bias. And, you know, I do have quite a lot of sympathy for people who did go through their training 20, 30 years ago and were taught overtly racist and dehumanizing things, because they're carrying that around because someone handed that to them in their training. So we need some work for people to be unpacking their own racism, because there's no way the average doctor is going to say to a white man, hey, I treated you that one time at the hospital, can I use your garage as storage? You know, these boundaries are breached because we're objectified and dehumanized. And I think that academia has a big part to play in that, but not just in the teaching perspective, but also within research. If you want to research Indigenous people, there are grants, right? Like, it is a tasty area for researchers. They love a nice ATSI grant. But where are the Aboriginal people at the start? Where are the people and the collaboration to make sure the questions you're asking haven't already been asked, to make sure that the data you're gathering is actually appropriate, and to make sure that it's ethical? Because in the same way that we have manels, it's really common at conferences to watch an all-white panel of professors talk about an Indigenous people study. And you sit there and you're like, that's wrong, no, that's not what that word means. And this flows on into the healthcare sector, because how that data is then interpreted is wrong. It's misunderstood. You've misunderstood the words used, or you've been given incorrect information because the way you approach the community, you weren't actually trusted. So I think that it's very much an interweaving of making sure that research is done in a more ethical way, that we have more partnerships and collaboration, that academia becomes safer so that we can have Indigenous professors in the field. And then we need all of the healthcare professionals out there to go and engage in their own personal and professional development beyond what your workplace is making you do, like the box or the one-day training, so that you can engage in your own learning and keep yourself up to date on the history and the present of Black politics here, because that impacts our health. And so it's important for you to know when you're treating us and also working with us as colleagues.
Lauren, do you have anything to add from your perspective as a Black woman in America?
I've just been sitting here, I feel like shaking my head vigorously. I feel like Amy is my sister from another mother, because the experiences are just identical, it feels like, which really tells me that, you know, anti-Black racism is a global issue. It is not something that can be couched in one particular country or one particular corner of the world. every single thing that Amy has said, from her experiences seeking health care, from the conditions that are prominent within her family, within her community, to the challenges within the system of healthcare and the lack of diversity and the lack of representation, from the way that communities are exploited. It is as though we're living the same existence, just on different sides of the world. And so I see so many parallels, which is even more disturbing to me, to see just how insidious racism is, and how much of an intricately and generationally constructed system it is that still continues to work perfectly today.
Yes. And, I would add to that, Lauren, I think that a Eurocentric lens watching us talk right now would be tempted to think, ooh, Black people on different continents share deficits. And it's like, no, we share the experiences of colonization. So it's that flipping of the script to not go deficit model of Indigenous and Black peoples, and instead go, what is it about these systems, the way they operate and the way we deliver it, that's causing harm globally to Black and Indigenous peoples?
I couldn't agree with you more.
Look, there's a fantastic question here, Amy, for you from the audience, which is, how can we use our privilege as white women to elevate women of colour, and particularly from First Nations communities in Australia?
Yeah, great question. And I would refer to something that Elizabeth mentioned earlier about the importance of men speaking up. It's the same for non-Indigenous people speaking up for Indigenous people. So not talking for us, but calling out, like in that example about the man who waited and said, oh, well, the women have laughed, now I'll laugh too. So the power imbalance is what's key there. So whether it's in a workplace or you've got a patient, see another nurse watching the nurse, and they were watching, like I watched the other nurse watch and then not intervene, which meant that I spent the whole day not trusting either of them. She didn't say anything. Now, my fear was that she would go home and think, oh, well, my colleague asked that Aboriginal woman and she was fine with it. I wasn't fine with it. I was in a vulnerable position and didn't feel it was safe to say no. So within my work, so I've just completed a national study around the country where I spoke with Indigenous academic women. And something that come up a lot was basic support in the workplace is often predicated on something as ridiculous as being liked. So if you're not liked or perceived as liked, if you're not smiley, if you don't code switch, if you're seen as the angry or the uppity Black woman, you're not going to get any support. And so we often don't have the power to call it out in that time when we're in precarious workplace or we're the patient. You do. Talk up, say, that's a really racist comment. And then don't turn to the Indigenous people and be like, don't you think? Come on into the conversation. Just call it out. That was really racist. Hey, you've actually written a slur into this study. Let's take that out. Speak up when you see racism. Speak out when you see sexism, because we have a power imbalance in that situation. And then also amplify. So if you're at that table and you're part of a research group who want to get that grant or the ARC or whatever it is involving Indigenous people, at that point, before you write the grant, say, who's a great Indigenous researcher I can bring in? What's a great Indigenous organisation we can partner with? Speak up in those early days before we've been dragged to the table at the last minute as an RA, or in your practice or wherever you are. Speak up, because just because I'm sitting there smiling doesn't mean that I agree. It means that I'm in a vulnerable position.
Oh, strong call to action there, Amy. Thank you so much.